the operating table looked like a spit, a rotisserie that you would roast a chicken on.
Steve Carell's experience is not necessarily going to be your experience, but we're going to get started. Welcome to joint replacement class. So everybody in this room is having a hip or knee replacement. Everything is very similar. There's a few differences, which we will get to on the slides as we go. This is Scott. He's our director of physical therapy. He's going to speak with me. At the end, this is a large group, so I really ask if you do have a question to try and hold it till the end. Jot it down on your paper. Most likely, I will get to that question maybe on the next slide or anything like that. And then at the end, there will be an opportunity to ask questions as a group. So you're all here because you're having pain related to a hip or a knee. Many people don't realize, well, everybody knows we do joint replacement because that's why you're here. Many people don't know that Dr. McComas is a board certified spine surgeon. So we also do back surgeries. We do sports medicine. We have some fellowship trained physicians in sports med here. Podiatry, we have Dr. Schumann, who joined us about a year ago, who does podiatry. And we have rehabilitation, which means physical therapy. We have our own PT on site. Femur, which is the largest bone in your body. The tibia, which is the shin bone. The patella, or the kneecap, and the fibula, which sits over here. The orange represents the cartilage that coats the bones. The hip joint is a ball and socket joint. So we have the femur here as well, the ball, and it sits inside the acetabulum, which is part of the pelvis. Now there's cartilage on both sides of the acetabulum as well as the ball. So this is actual picture of an arthritic hip. As you can see, the cartilage is kind of rolled up on itself. I like to describe it like a piece of saran wrap that's rolled backwards. There's also those big knobby bone spurs at the bottom. And all of that contributes to that locking, clicking, catching feeling, grinding, painful sensation you're having is because the joint is uneven. So all we need is a regular x-ray to diagnose arthritis. All of you have had an x-ray. If you are curious about what your x-ray looks like prior to surgery, just let us know. We can pull those up for you. For a hip, there should be a thick black line that runs throughout the entire hip area here. This patient's completely lost that joint line. You see they've developed a very large bone spur on the outside there. Knee, similar, thick black line should run throughout the inside of the joint. This patient has completely lost that joint line and developed a very large bone spur on the outside of the hip. So the knee replacement itself is made up of 4 pieces. The first piece is called the femoral component. It goes onto the femur. There's a plastic spacer and then a tibial component which goes on the tibia. You also get a new kneecap. So I like this picture because it kind of shows Dr. McComas turns your kneecap over and attaches that kneecap to the back and puts it back. So when you feel your knee, you still have your kneecap. A lot of people think this is, get confused and think they have a brand new, the whole kneecap is new. It's really just a button on the back side there. The hip is also made up of 4 parts. There is a metal cup, a plastic liner, a ball, which is made of usually ceramic. He talked about the squeaky hip in the video. The squeaky hip happened because they used to have a ceramic cup and a ceramic ball. So ceramic on ceramic, you can imagine, right? Now they figured that out, and now they make this plastic, just like the knee. So the squeaky hip problem, you don't have to worry about your squeaky hip. And then a stem. The stem goes down into the femur. A lot of people worry that the stem is going to hurt to the thigh. It does not. Your femur is hollow, so he just uses a tool to kind of tap that stem down into your femur. There's no pain caused from that. Implants. Dr. McComas uses DePuy, D-E-P-U-Y. He has been using them for over 20 years. He's very happy with them. There are no recalls. If you drive down the road, down Route 30 all the way to Warsaw, their factory is there, and that is where they're made. He told me a story just recently, actually, at our conference, that Supposedly, Depew was coming through the state of Indiana on a wagon, and his wagon broke down in Warsaw, and he met the farmer's daughter or whatever and got married. So I guess Depews have been in Warsaw for over 100 years. All right, so Scott's going to talk about getting your home ready.
Okay, so as far as getting your home ready, you want to remove all the throw rugs out of your path, any tripping hazards pretty much. I hope you don't have any cords in your hallways. Moving things within reach. Okay, so that means medications, your phone especially, any cooking utensils, pots and pans that way you don't have to squat down or go on your tiptoes to get them. Widen your pathways to get a walker through, but do not rearrange your furniture. If you rearrange your furniture, you might get a little confused in the middle of the night, bump into a couch and fall. We definitely don't want that. So make sure you don't rearrange anything. And prepare and freezing nutritious meals after discharge. That's going to help you with recovery, getting proper nutrition, staying hydrated, and it's going to stop you the hassle of having to stand for an hour or two straight while you're cooking. And possibly considering altering sleeping arrangements, especially if your bedroom is upstairs. That'll save you the effort of having to climb stairs. And as far as what you want to bring to the hospital, if you have a walker on hand, definitely bring it. If you do not, you can also get one from Amazon, usually. If Amazon's not something you use, you could get it from CVS, Walgreens, Target, possibly. Loose, comfortable clothing, enough for 3 days, just in case. And some flat, supportive walking shoes, especially non-slip. And a CPAP if you are using one. And as far as what you don't want to bring, anything that you can lose that's valuable. So credit cards, money, valuables, jewelry. And as far as medication, you do not have to bring that. When you talk to the testing place who will talk to you before the surgery, you will tell them what types of medications you're on, and the hospital will have them on hand for you.
Okay, so we're going to talk about pre-admission testing. The hospital will call you and do a phone interview about 7 to 10 days before surgery. During that time, they'll explain what time to come to the hospital, what medicines to take before, what medicines to hold. So they instruct you on all that. They will make an appointment for you to have some blood work, EKG, urinalysis, and a nasal swab prior to surgery. Now, some of you may have done that with your family doctor or, on your own. And if you've had some of those done within the past 30 days, they won't repeat them. Then patients having hip or knee replacement will have a hip or knee x-ray on the non-operative side. Now, most of you, if you have a pre-op appointment with us, we will do that here at that time. Sometimes if I scheduled your surgery rather quickly or within like 4 weeks' time, we'll do it before you go home that day. So I just like to mention it is done on the non-operative side because we want to make your bad knee like your good knee or your bad hip like your good hip. And then I do have, if you guys want to jot this down, it's the PAT testing phone number. I always have you write this down just because, say you work and you can't answer your phone during the day, or it's been 6 days before surgery and you haven't heard from them. Give them a call and they'll be able to assist you. Or you forget, am I supposed to take my aspirin or not? That's the phone number to call. Anesthesia. So you'll have spinal or general anesthesia. Most knees will have a spinal and a regional block. Just because you have a spinal does not mean you're awake. You are asleep. You don't hear him working. I've worked for Dr. McComas for 10 years. I've never had a patient say to me they woke up and heard his music playing. Okay? So you guys are good there. For hips, it's a general anesthetic, which means you are intubated. You'll meet your anesthesiologist prior to surgery. If you've had problems with anesthesia in the past, that's your time to say, hey, it makes me nauseous. Hey, I get the shakes afterward. Hey, I really want a spinal instead of general. I mean, we run into that once in a while. That's the person to discuss that with. Starting a few years ago, Munster, I have to change that. It's now called Powers Health. Started what's called an enhanced recovery after surgery. What they found is patients who are better hydrated going into surgery come out of anesthesia better and have less complications. So you will be instructed to drink 20 ounces of light-colored or clear Gatorade 2 hours before your arrival time. So if the hospital tells you have to be at the hospital at 7 a.m., you're drinking your Gatorade at 5 a.m. Okay, this is correct. This also includes a pain medication cocktail after surgery. which includes Celebrex, which is a non-steroidal anti-inflammatory, or an NSAID, like an ibuprofen, or it's a very strong anti-inflammatory. Gabapentin, or also called Neurontin, that is to help with nerve pain. And Tramadol, which is a narcotic. So that cocktail will be given to you during your post-op period, and you will get prescriptions for all those to go home with. If you don't tolerate any of those medicines, we won't give them to you. You have an allergy, they upset your stomach, things like that. So, but that seems to work for about 80% of our patients. For that 20% that it doesn't quite work for or control their pain, we can switch you to something stronger like Norco before discharge. Refills. So when you leave the hospital, your prescriptions will be sent electronically over to the pharmacy of your choice. The hospital also has their own pharmacy. Some people choose to have it filled there and then pick it up like on their way out. I think they even deliver them to your room. But anyways, that's an option. Those should last you to your 2-week post-op appointment. If they do not, give us a call and we can refill them. Long as we're in the office Monday through Friday, we can refill your prescriptions with a phone call. So the next few slides are complications of surgery. So we're going to go through several complications and what we do to prevent them. So the first one's nausea. Nausea happens because of the pain medicine, the anesthetic, you're not eating and drinking enough. So if that happens while you're in the hospital, there is already a medicine that the nurses can give you. You just have to request it. Sometimes the nausea doesn't happen until you go home, like you're fine post-operatively, then a couple days later you're getting nauseous. If that happens, call me. I can order that same prescription to your pharmacy, and it usually goes away within about a week. Constipation. Constipation happens because we're not moving, we're not drinking enough water, the narcotics. So if that happens, I will tell you to take milk of magnesia. So everybody has a shopping list in their folders. So milk of magnesia is on that shopping list. If you are prone to becoming constipated, a stool softener is nice to start taking. But once the problem happens, milk of magnesia. Stool softener is not going to do anything. Swelling. Swelling is normal. Swelling may occur your entire leg. Even if it's a hip replacement, your whole leg may swell. So we're going to have you ice quite a bit. Our knee patients get the polar ice machine. Our hip patients get ice packs. Compression stockings, which we'll talk about. And elevating when you can. But swelling is normal. So this is a picture. So only our knee patients get the polar ice machine. It's a little cooler with the tubing. It's filled with ice and water. You can use 12-ounce water bottles and freeze them. They fit very well inside there. And then you have to have a little water circulating, and the water circulates and goes around your knee. You have to have something between the pad and your skin, because it could get too cold. I usually recommend like a pillowcase. Blood clots. With any surgery, especially orthopedic surgeries, you have a risk of getting a blood clot. So to prevent that, we're going to have you on a blood thinner after surgery. Usually it's aspirin twice a day, morning and night, full strength. You will get a prescription for this. You don't have to buy it. Some people who are at higher risk or can't take aspirin will be on a Lovenox shot, which is a shot in your stomach. If you're on the shots, the nurses will teach you how to give that to yourself or a family member before you go home. But I would say 90% of people are on the aspirin. Also, if you're on a blood thinner right now, let's say you take Coumadin, Xarelto, Effient, any of those, you just go back on your regular blood thinner after surgery. You don't have to worry about this part. Compression socks, they have to be worn for 4 weeks after surgery on both legs. Very important. I get that. Every once in a while I get someone with one on the non-operative leg, with one on the operative leg. Stockings, both legs. They are the knee high. They are the TED brand, T-E-D. If you want to buy a second pair, you can buy them on Amazon. If you're not sure on sizing, you can ask your nurse because they're going to put one pair on you before you go back. You can ask them, what size are you putting on me? And then get on your phone or have someone get on the phone and order them on Amazon. Okay, I'm an XL, They'll be there the next day. You can remove them at night. Okay, they are tricky to get back on. There are some tricks to doing this, or I've suggested letting your physical therapist help you put them on the next day. I'm sure the therapists love that, but that's an option if you're struggling to get them back on. Very important to wear them. And then moving. The more you move, your risk of blood clot is lower. Stiffness happens because we're swollen, because we just had surgery. So we're going to start physical therapy right away. Home exercise program. In your folder, there are exercises for hip and knee. If you can do those prior to surgery, they're helpful. They are not required. So say you try doing them and they hurt, don't do them. But they're a nice start to what you're going to be doing after surgery. And then a CPM machine. So this is for our knee patients only. This man is using what's called a CPM machine. It stands for continuous passive motion. And you lie down either on a couch or a bed. You'll start using this in the hospital, and then a unit will be delivered to your home. And it moves your knee for you. You do nothing. You just lay there and it moves your knee. You're supposed to use it for 2 hours, twice a day. Some people, I would say most people love this machine. Few people can't stand it. If you can't stand it, it's okay. You don't have to use it. But it's no work on your part. People find it relaxing. They can sleep with it on while they have it on. Infection. So we want people who are sick to stay home and stay away from us, especially those couple weeks before your surgery, because we don't want to get sick and have to postpone things. Specialty dressing. We'll get to that on the next slide. Soap, you're going to be instructed to wash with soap the night before surgery. The hospital gives you the wipes to clean your skin. When you do that pre-admission testing, they'll give you those. And then flu shot, COVID shots, okay, I prefer no sooner than 2 weeks before surgery, just because, sometimes you get some symptoms with the flu shot or the COVID shot. So this is hip. My knee patients can take a break. You will wake up with one of two types of dressings on your hip. The first one's called a PICO, P-I-C-O. It's a white dressing and it has a clear border, okay? And then it's this little tubing with a little battery pack. The battery pack's about this big. And what it does is provide gentle pressure to your surgical incision. So gentle you can't feel it, but it does help with wound closure. Or you will wake up with what's called a honeycomb dressing, which looks like a honeycomb, has that clear border. Both of these you're able to shower with, so that's nice. The PICO, you just disconnect the battery pack right at this hub there, put it on the counter, shower, go back out. They're a 7-day dressing. They stay on you for 7 days. At 7 days, it gets changed to another honeycomb, which will be in your discharge folder that you get from the hospital. So you're either PICO to honeycomb or honeycomb to honeycomb. 7-day dressing. When you come and see me or Dr. McComas at your 2-week post-op visit, we take that off. You're closed with steri strips and glue. There are no stitches, no staples that need to be removed with hip replacement. Our knee patients are not quite as fortunate. You're closed with staples. Those staples have to remain dry. So we recommend sponge bathing during the time after surgery or being very careful. I have patients that do get creative and, put a garbage bag over their leg and have a walk-in shower and this and that. I do not encourage that, but everybody does their own thing. Have to stay dry. Those staples will come out at that 2-week post-op visit, and then we put steri strips on and you can shower. It's covered with, it's called a Primapore. It's a white dressing with like a paper tape border. The hospital will give you like 5 or 6 extra ones in your discharge folder, and that gets changed every 2 to 3 days if it looks like it's soiled or anything. All right, physical therapy.
All right, so our rehab team is going to work with you to improve your functional abilities. You're going to encounter both physical therapists and occupational therapists. The physical therapists, they're going to instruct you on transferring, which is getting in and out of a chair, in and out of the bed, etc. Walking with walker, strengthening exercises, negotiating stairs if you have to, and reviewing your precautions. Occupational therapists, they're going to work on transfers as well, using the walker and any type of sock assist that you have, and self-care activities like getting dressed and stuff like that. And like I said, our goal is to get you to reach a maximum level of independence before you're discharged from the hospital and then discharged from outpatient therapy. So, like I said, you'll get PT and OT in the hospital. In most cases, after you're discharged from the hospital, you'll be getting about 2 weeks of home health therapy that the hospital sets up for you. At your 2-week post-op visit, most patients will get referred to outpatient therapy. However, especially with our physicians, we give you guys your order way in advance. That way you could set it up 2 weeks post-op very early. That way there's no delay in your treatment. And you could also go wherever you want.
So 2 weeks set at home, set up at the hospital. You don't have to do anything with that. The hospital sets it up for you. The outpatient is done by your place of your choice, and to set that up as soon as possible. If you want to come to PT with us, I highly recommend on your way out today making your first visit. All of you have a surgical date. 2 weeks after surgery, you're going to be coming to see me and Dr. McComas, and then you could start outpatient therapy. Okay? And then if you do need a recommendation for something, like say you live in Lowell or somewhere farther and you need a recommendation of where to go, ask me and Scott at the end. We can help you. Mm-hmm. All right, so we're rounding third, heading for home. These are my last few slides. I call them my hodgepodge section because they're like places where I didn't know where to put other information. It's just a lot of odds and ends. So after I'm done with this section, then we'll open up for questions, okay? So anti-inflammatories. So anti-inflammatories are ibuprofen, naproxen, Aleve, meloxicam, Celebrex, what else? Voltaren, diclofenac. Any of those drugs need to be held 7 days before surgery. They do thin your blood. We don't want that interfering with your surgery. After surgery, you're going to be on Celebrex, remember, and that is one of those, that's a drug in that class. You're going to be taking that for 2 weeks after surgery. So while you're on Celebrex, don't take any Aleve or ibuprofen. That substitutes for that. And then I like you to take a little break for a couple weeks because if you remember, you're going to be on aspirin, you're going to be on Celebrex, and all that can be hard on your stomach. So I like you to take a break for a couple weeks after the Celebrex runs out. You will have your pain medication still available to you. And then once you're off your aspirin, your TED hose are gone, the 4 weeks after, if you want to take Aleve or ibuprofen or something instead of your pain pill, that's fine. If you have questions about this, because it can get a little confusing, just ask. Dental work or colonoscopy. For a year after surgery, you'll need to take an antibiotic prior to any dental work or colonoscopy. It's usually amoxicillin an hour before you go to the dentist or clindamycin if you are allergic. I will give this to you. I'm really good about asking you, are you going to the dentist anytime soon? We ask that you don't have any elective dental work or colonoscopy for 3 months after surgery. The theory is you have bacteria in your mouth, you have bacteria in your colon. There's no really way to clean and scrub your mouth or clean or scrub your colon. It's just preventative because the theory is bacteria can get in your bloodstream, cause a problem. If you go have a biopsy, like your skin, you go to your dermatologist, they can clean your skin before they do the procedure. Same thing if you have your gallbladder out. They're going to give you an antibiotic before your procedure. So this is really only dental work, colonoscopy, okay? Air travel. So if you go through the airport, through the thing, you're going to beep. Not always, but you can beep. So just tell them that you have a near hip replacement and they will wand you. Sometimes you will go off, sometimes you won't. We used to give out pocket cards. TSA does not care about a pocket card. They'll just, like I said, usually go through the one that's like this and it goes around you. Numbness. Numbness is normal after surgery. For our hip patients, it's usually lateral thigh, can go down as far as even to the knee. It resolves slowly, meaning it could take months. So it'll start to resolve and get better. Sometimes your incision is here in the groin this way. Sometimes you'll still have some residual numbness even at a year, but it's completely sensory based. Has nothing to do with the nerve working, being able to lift your leg, etc. Our knee patients, it's usually on the outside of the knee. Same thing, it does get better. There might be a little residual at a year. Physical therapy, if it's really bothering you, sometimes it's a hypersensitivity, like your sheets touch along your incision and you're just like, ugh, feels so weird. Let your therapist know. There's some desensitization techniques they can do in PT to help get that better, okay? But it will get better. And remember, you're gonna be on that gabapentin after surgery, and that helps with that. Driving, that's a big one. Everybody wants to know when they can drive. Left leg, usually 2 weeks if it's your left side. If it's your right, we'll check your strength at the 2-week mark. Sometimes they say do a little bit more therapy. See how you do, might be 3 to 4. Dr. McComas's rules, if you're using a cane, you can drive. So if you're off your walker, you can drive. All right, so I have one more thing to add about our hip replacements. Dr. McComas does what's called an anterior hip replacement, so you're cutting the front. There is a different way of doing a hip replacement called a posterior approach, where you're cutting the behind back here. If you wake up and your incision is here, you had an anterior approach. That's what you want, okay? What's great about the anterior approach is smaller incision, faster recovery, less pain, less restrictions. So you have no restrictions. So if your neighbor's talking to you and they're like, oh, my sister had her hip replacement, she couldn't cross her legs and she had to have a raised toilet seat and she had to sleep with a pillow between her legs and all these things, just smile and nod, okay? Because I'm sure they had it this way, okay? If you have an incision in the front, that is an anterior approach, okay? And Dr. McComas 99% of the time does an anterior approach, okay? If a therapist or someone caring for you is telling you you have restrictions, I ask that you give me a call and let me know. I can call and talk to them. Sometimes they're not familiar with maybe they're new to this area, and I just use it as a teaching moment. You're not getting anybody in trouble. Okay, so that's it. You guys were a great group. Anybody have any questions? Okay, I'm gonna start in the front and work my way back. Go ahead.